Okay. It's visible now, yeah?
Yes.
All right, that's fine. Okay. Assalamu alaikum, everyone. I hope that everyone is doing good, and I hope staso tirshui akhtar ham khatir shui. And the next lecture is about asthma and bronchiectasis. So for the lecture ki mungo detail ki nuzu asthma management ta like dari treatment bara ki because aga tasta ratlun ki lectures ki agi bara ki tasta well kigi. And first, I'm gonna obviously speak in English, and then I'm gonna translate it to Pashto. So I'm gonna share the English ki aga Pashto kimbe aga wema. Okay, so let's start. So asthma, it's a common form of obstructive lung disease, and it's characterized by bronchial hyperresponsiveness. Opudi ke airways to the inflamed kigi, ari ke izafa mucus ham produce kigi, or porque airways to the aga constrict kigi lakayanazan tangay, so that the main definition da they constrict triggers such as like cold, air, dust, pollen, exercise or smoke, and we're gonna go like in more detail about its etiologies and its causes. And the common form to the atopic form da, so like atopic asthma is the most common form of this. So this is just an introduction. Katasu the normal airways da. An asthmatic one of Vedic, you can see that the areas have constricted. There's also production of mucus. The walls are inflamed, and during asthmatic attack, it constricts even more, and the smooth muscles tightens as well. So that's it. So various forms of asthma. As mentioned, that atopic asthma, it's a classic example of type 1 hypersensitivity reaction. So it is basically IgE-mediated reaction. And the disease usually begins in childhood, and it's triggered by environmental allergens like a dust, pollen shower, animal dander, and certain food items. And positive family history of asthma is also common in these people. And usually a skin test with offending antigen in these patients usually give you a wheal and flare reaction, and it's usually diagnosed based on the total IgE level. So for asthma kichida munga atopic asthma laru, munga non-atopic asthma laru, drug-induced occupational asthma. Or for the total kichida atopic asthma aga the common form da. Awaga chida your example that the type 1 hypersensitivity reaction. Just give me a second, please. The reaction that the type 1 hypersensitivity example that the type 1 hypersensitivity reactions. They usually chida the childhood yani mashum tub ki paida kigi, or the triggers chidi kamshe chida pare is usually dust there like khawri, pollen show, the animal yani vichta, dander, yeah, certain food items show, or padike family history chida the family history ham important da, so it runs in the family, or bal as we said, like serum Ig levels per atopic type ki level to increase kigi. And then you have got non-atopic asthma. And in this one, you don't have any evidence of allergen sensitization, and skin tests are usually negative. So there's no need to have a positive family history in these patients. The most common form in non-atopic is usually respiratory infections to viruses like rhinovirus, parainfluenza virus, RSV viruses as well. These are common triggers. Inhaled air pollutants like a tobacco smoke, sulfur dioxide, nitrogen dioxide. So these chemicals, these gases, they contribute to the chronic airway inflammation and hyperreactivity in some cases. And as already mentioned, in some instances, the attacks may be triggered by like harmless events as well, like exposure to cold or even exercise as well. And then you have also got the drug-induced ones. So this is when like several pharmacologic agents provoke asthma. So aspirin, the sensitive asthma, is a common example of this type, and it occurs in individuals with like recurrent rhinitis or like a nasal polyps, and these individuals are sensitive to small doses of aspirin. So small dose of aspirin can trigger asthma in these individuals, or other non-steroidal anti-inflammatory medications. They can also experience asthmatic attacks. It can also form urticaria as well. So per non-atopic asthma كده أغيكي يعني allergen it's أغيكي allergen sensitization evidence نشتا بكي أو skin test the allergy كده أغام بكي منفيدة يعني negative the family history بكي دومرا important ندا بدي type كي أو usually the day وجه شي أغا respiratory infection سي like rhinovirus show para-influenza virus show RSV virus هنا شو شيء دا non-atopic asthma cause كي أو بكي like air pollution मतलब बद हवा ची gases different gases ची हवा की बद हवा like tobacco smoke show sulfur dioxide nitrogen dioxide that tool inflammation inflammation cause في the airways أو داغي hyperreactivity as well. Or drug induced كده يعني بعض medications دي شيء asthma cause like aspirin your normal example the day type or other non-steroidal anti-inflammatory medication هم asthma induced كويشي and aspirin is usually أغاب ذكا asthma cause كده داري pathophysiologic this is like aspirin كده أغا inhibit K-cycle oxygenase pathway of arachidonic acid metabolism and the last does prostaglandin E2 the aghi level kamigi and kala the prostaglandin E2 level kamshi no aga enzymes like pro-inflammatory mediators to inhibit K usually aga nishika wala the action of perform ki so they are not able to inhibit the pro-inflammatory mediators like a leukotrienes show or and then as a result of that, the mediators, the pro-inflammatory mediators, they level dirigi, or as a result, they play a central role in inducing the aspirin-induced asthma. And the fourth type is the occupational asthma, and that form usually triggered by fumes, triggered by certain like chemical basically chemicals like بعض كيميائي موادنا شي يا بعض غاسونا شي أغا occupational asthma trigger كي and that type كده ده usually أغا خلقو كي common ده سوق شي for example factories كي كار كي يا سوق شي ده غسي بعض كيميائي موادنا سرا دير كار لري أغا خلقو كده دير common that type but the most common type is obviously atopic asthma. So if you go to its pathophysiology. So the molecular pathway that leads to asthma is actually pretty complex because it's often initiated by environmental triggers, as we mentioned. And in asthma, there's often an excessive reaction from type 2 helper cells against specific allergens. So type 2 helper cells, these are immune cell subtype which are known to be involved in asthma, as well as like in other atopic reactions like atopic dermatitis, allergic rhinitis, which makes up something that's called as atopic triad. What happens with asthma is that allergens from the environmental triggers like a cigarette smoke, these are picked up by the dendritic cells, which then presents them to T helper cells, which then produce cytokines like interleukin 4, interleukin 5, which then leads to a number of features of asthma. So example, interleukin 4 like leads to production of IgE antibodies, which coat the mast cells and stimulate them to release granules, as you can see it here in the second picture. Oh, it's not really clear. It's okay. I'll fix it when I upload the presentation properly because it's not showing clearly. But you can see that these IgE antibodies that coat the mast cells, these they take like allergens. And then what happens is that they stimulate these IgE antibodies which coat the mast cells. They then stimulate them to release like granules containing histamines, leukotrienes, prostaglandins as well. And interleukin 5 on the other hand, this activates eosinophils, which is also immune cells, and they promote an immune response by releasing more cytokines and leukotrienes. So in this case, since IgE antibodies are being produced, this is an example of type 1 hypersensitivity, and this leads to 2 serious events. So the early one is that minutes after the exposure to the allergen, what happens is that smooth muscles around the bronchioles they start to spasm, and there's also increased mucus secretion. There's also increase in vascular permeability, and also recruitment of additional immune cells from the blood as well because of the vascular permeability. So this the top one. This is like the normal bronchus, the normal bronchus state. But when there's an allergen, dendritic cells like present environmental like a trigger, so like allergens show in the form of antigen to help a two cell. And then what it does is that T helper 2 chidi agui cytokines produce kayo cytokines chidi aga like a peptides rundi di small proteins di che agui release kay interferons, interleukins, and dagashina release kay chemicals release kay that affects the other cells. And what happens is that, for example, the cytokines chikala release show, example, interleukin 4 ka release show. No, what interleukin 4 example does is that IgE antibodies stimulate K or IgE antibodies, as you can see here. Okay. So these are the IgE antibodies, and so the allergens basically these are being stimulated, and these antibodies they basically coat the mast cells. And the allergens ratio, antigen ratio, what they do is that they secrete the inflammatory granules. They do secrete K, and what they do is that when this gets activated, the inflammatory substances like a cytokines show further on leakage to release the mast cell na the inflammatory substances kana da zumunga bronchi airways affect kay padir tariqo sara. Example the zumung the smooth muscle constriction cause kay mucus secretion chida dir kay vascular permeability cause kay recruitment يعني نور immune cells chidi زمون دفاعي حجرات chidi the blood cells na chidi زمون the blood na di dil tarazi to up, and it results in like a asthmatic reaction or asthmatic attack. And what happens is that initially these inflammatory changes are completely reversible, but over the years, irreversible changes can take place, like edema, scarring, fibrosis buildup, and they can lead to thickening of the epithelial basement membrane, which then permanently reduces the airway diameter. So what happens? Inflammatory reaction شيء جدل تأكر كيجي the وجنا that type 1 hypersensitivity reaction كده ده كلاش inflammatory changes كوسكي ده أصل كي أول كده reversibly مطلب ده بيرت هم جوري ديشي يعني بيرت normal state هم تلاشي but مرور ده وقصرة over the years ده irreversible كيجي يعني كلاش ده asthma progress أوكي no ده irreversible كيجي مطلب ده بيرت قبل normal state تنشت له no and then changes hum delta be take place ke laka edema be razi edema occur kigi laka sanga scarring be occur kigi fibrosis hum build up kigi, and and this gachida be permanently the airway diameter sakai noram tanke yani noram permanently airway constriction cause kai. So that's the pathophysiology. Wait, it was just so in terms of its symptoms, what we have is that there is a symptoms can be variable in nature, and they consist of breathlessness, they consist of chest tightness, wheezing, and cough as well. They can resolve spontaneously or after treatment usually. So cough can be the sole symptom, and in some patients, symptoms for other allergic diseases, most frequently allergic rhinitis, may coexist with it too. Symptoms are characteristically episodic and it occurs at night. So it's episodic, like, which means that it's worse in morning times and also at night times. So you can experience like fatigue, trouble sleeping as well. So symptoms شدي كان أغا breath يعني shortness of breath like نفس بندي شي chest tightness شي لك تخي wheezing soundy أو أغا دا symptoms usually كلا treatment respond بيرتا سكي جوريجي so after the treatment and usually fatigue hampakik where because like stertia normally because of difficulty of breathing and sleeping ham trouble due to like tuhi the vagina ya wheezing the vagina ya nafas tang bandi the vagina also per sleeping ham difficulty or usually these symptoms chidi kana aga the shpe the khana or the sabi the khana dir say worse yani خرابي symptomونه دير apparently the sabi or the شبه دخوانا أو usually كذا signs like signs in terms of signs also ronchi can also occur, which is a bilateral diffuse bilateral mainly like expiratory the ronchi sound, and also prolonged expiratory phase can also be present, and these are sometimes observed only during forced expiration and may be absent in very severe exacerbations usually. And signs and symptoms of asthma are often absent in periods between the attacks or like exacerbations. And usually is expiratory phase and exhalation phase agadir ugday pa saki pa asthmatic people ke. And kalachi asthmatic attack paki symptoms dumra apparently perisab yani during forced expiration maybe yes. Yeah. So these are the clinical signs: wheezing, ronchi, prolonged expiratory phase show signs and symptoms of asthma absent in the periods between the attacks or exacerbations. And in terms of complications, I just want to see if I've skipped anything. So in terms of complications, if asthma is left untreated, it can lead to several complications. So it can lead to, example, respiratory infections. People with asthma are more susceptible to respiratory infection like a pneumonia, and so infection in these people can be more severe and they can be more long-lasting as well in individuals with asthma. Status asthmaticus, this is a severe and life-threatening form of asthmatic attack that does not respond to initial treatment and therefore requires immediate medical attention as well. Pneumothorax show, then you have also got, which is actually, pneumothorax is actually rare. Respiratory failure show, so in respiratory failure in these cases the severe asthma attack can cause obviously failure of the respiratory system, and this is when the lungs no longer function properly to supply the body with oxygen. And you can also have like side effects of medication. So some medication used to treat asthma, such as like corticosteroids, can have its own side effects like weight gain, show mood changes, or further increase of infections. And also in other cases, in severe asthma types in these people, there's also decreased quality of life as well, because it can actually interfere with daily activities and therefore decrease the quality of life for a person if it's poorly controlled, if it's not being controlled properly. So complication the asthma chida aga chikala asthma be sa bela japati shinu agiki obviously aga severe complication warki occur ki like a respiratory infection paki normal asthmatic halki ki respiratory infections dir be common like a pneumonia show or the infection chi aga dir long lasting yan dir damam warki or dir yani severe yani khatarnaki, if that's the right word to use. Status asthmaticus hampaki dayo life-threatening asthmatic attack da che di khatara emergency treatment pakarda. Pneumothorax hampaki lekin dumra rare ke and dumra adina da complication or respiratory failure can be a complication of respiratory failure ki chida like lung say function kaina nose ka zamung wujud ta chida say oxygen na supply kigi or side effect the medication the drugs che asthma work wal kigi aga side effects ham lari like a corticosteroids che show aga khpala side effects lari like sanga che wazn agashtal again yani the infection risk dir kai or زموږ په moods کې سم راوړي بدلاو هم راوړي او بل د یو انسان کوالټي د لایف چې د هغه هم ریډیوس کیږي که چرته د اسما پولی کنټرول یا سیویر فورم because هغه انسان نشي کولای چې نورمالي خپل ډیلی اکټیویټیز هغه کیری اوټ کی so that's and in terms of the just I think I missed something out. Do that later. So in terms of the diagnosis of asthma, it starts with initial detail of respiratory history and examination. So if there's a high probability of asthma, which is based on these assessment, and treatment can be initiated and monitored with spirometry and symptomatic scores. So initially the asthma diagnosis chida kana aga usually chida aga awal it's aga history band based that your patient history band based that your patient physical examination band based or the aga basis band chikala push the increase the yani asthma yani سل يعني دير مطمئن أغا دكتور تشي دا واقعين أسما دنو أغا ورتا treatment start كي يا أغا monitor كي spirometry سرا يا symptom scores as well and that's in these cases, but in cases, so spirometry findings usually that are suggestive of asthma includes that FEV1 and FEV3 ratio to that are usually 75 or 70 percent between below 75 yeah 70% da no kalachi FEV1 and FVC ratio chi aga chikala the 75 na ya 70% na landi no aga air flow obstruction indicate kai aga asthma na indicate kai lekin kalachi the FEV1 che kala chimunga bronchodilators worku laka short acting beta agonist ka warta worku opdi halat ki the bronchodilators improve the FEV1 improve ki by 12% no da asthma suggest kawaishi And another one is obviously the bronchial challenge test, and this is usually occurs if asymptomatic. If it's asymptomatic, so most often used to establish a diagnosis when spirometry is normal, and it's widely used is methacholine inhalation test. So what methacholine does is that when you give it, it will cause, if it's asthma, it will cause bronchoconstriction, and this could indicate asthma usually. But usually the positive bronchial challenge test, it's not very specific, and but if it's negative, it can exclude asthma. So bronchial challenge test da padiki methacholine inhalation yani methacholine warta warkol kigi or kalachi methacholine like vasoconstriction cause ki yani tangwale the bronchi the airways cause ki no matlab aga the asthma indicate kai lekin da yo specific test na da asthma da khatara lekin kalachi da test manfi uzi negative uzi da kumak ki che asthma seki exclude ki yani like count niki asma mutmain yani agu mutmain ki tachi da asma na da hisab or both chest radiographs like chest x-rays, these are usually normal. So during asthma exacerbation, radiographs may reveal features of hyperinflation or certain complication of asthma exacerbation like pneumothorax can be visible as well in these types. So an IgE dependent allergic test as well can, so this dagat IgE dependent allergic test that usually we do it like in atopic asthmatic people can. and that suggests atopy. So the skin prick test where and it also involved like specific serum Ig levels are checked to identify allergens, which causes sensitization in patients with allergic asthma. Or well, basic blood test ham kigi like a white blood cell count little key KCRP to see the infection risk or also to see for eosinophilic count as well. And again, as I mentioned, total Ig paki ham sikigi seen kigi or yeah, that's what this is. Then I think I missed out something. It's missing a slide from what I can see, but I can talk about the slide that's being missed, like, and then I will incorporate that slide once it's once the presentation is finished. So in terms of asthma, Chida, we have like intermittent asthma. So there are different types of asthma. So from least to most severe types, there's intermittent asthma, which let me see if I can find it all the way bottom. No. Okay. So asthma, it can have like different types, like you can have intermittent asthma. So intermittent asthma, it's the mildest form of asthma that it describes asthmatic symptoms which requires rescue inhalers and used no more than twice a week. Also involve nocturnal symptoms. It occurs like less than twice per month, and the symptoms usually do not interfere with the patient's daily life as well. Normal pulmonary function test, and when asymptomatic, this type is treated with inhaled short-acting beta agonist. So there's actually a few types of asthma. Your intermittent asthma show, bulky persistent mild asthma show, moderate persistent asthma da, and then agadir severe form da aga severe persistent asthma da, or intermittent mild asthma da mild form da the asthma, or padi ke da inhalers chidi da saba chida inhalers medication aga khali pajuma ki دوزلي استعمالي no more than twice a week او بدي کې يعني nocturnal symptoms مطلب د symptoms چې د شپې د خوانه پیدا کیږي هغه اصل کې خالي دوزلي په میاشت کې ای کله چې intermittent asthma ای کله چې intermittent asthma ای او بل just give me bear with me for a minute. I'm so sorry for the interruptions. And then a persistent mild asthma chida دي symptoms chidi kana it involves most days of the week, like a cough, dyspnea, wheezing. Nocturnal awakening occurs like 3 to 4 times a month, and there's also need for rescue inhalers as well, more than twice a week. Pulmonary function tests are within normal ranges in these ones, and they're treated with inhaled glucocorticoids, both long and short acting beta agonists. So in persistent mild asthma chida بديك السيمتومونه chdi aga dir يعني بجمعك dir orazi يعني in a week, so many days in a week it occurs. أو بل the شبه دخانة السيمتومونه chdi aga usually 3 to 4 times per har miyash kya karke lake per intermittent asthma ke chida the shpe symptomuna chidi aga khali dozeli per miyash ke occur kigi lekin per persistent mild type ke chida aga ke da symptoms chida shpe de khana yani nocturnal awakening chwa to the shpe de khana cha occur kigi aga drina ter salur time sapori ar miyash ke occur kigi. أو inhalers كده كان أغا twice a week دا required لري. And glucocorticoids هم it requires glucocorticoids as well, and both, as mentioned, long and short-acting beta agonists. And then you have got a moderate persistent asthma, and in this type, the symptoms, they occur every day. Rescue inhalers, which is like short-acting beta agonists, these are required daily for the control of symptoms. Nocturnal awakening at least occurs once a week. And pulmonary function test shows a decrease of like 60 to 80% of the predicted normal value. Pharmacologic management involves addition of long-acting beta agonists to short-acting beta agonists, and there's also increased medication, medium dose of inhaled glucocorticoids. So yeah, and then you have got in severe persistent asthma. For severe persistent asthma kichida, they can the symptomatic attack like a tukhid, isabandi and wheezing chida da poraski ډیر ځلې کیږي او یو وړوکی غوندې اکټیویټي هم چې ای هغه دا شی ټریګر کوی شي، د دې سیمټمز ټریګر کوی شي، او د شپې د خوا سیمټمز چې هغه ډیر کامن په سیویر ټایپ کې. So you experience the symptoms every day and several times. Like a symptoms چې دی like a ټوخی شو، اسابندی شو، wheezing sound شو. So this is what I mean with the symptoms. This was what I just said. This was all about asthma, and now moving on to bronchiectasis. So bronchiectasis, دا also chronic respiratory disease disease دا او دې کې چې دی زموږ د airways چې دی هغوی abnormally غټ شوي دي، abnormally dilate شوي دي. There's a disruption of bronchi and bronchioles as well in the lungs, and elasticity چې دا هغه او mucus clearance mechanism چې دی هغه ټول impair شوي دي، یعنی damage شوي دي. elasticity damage شوي ده په bronchiectasis کې. There's a clearance of mucus from the airways هغه impaired یعنی damage ده په دې کې. او په دې کې لکه څنګه په اسما کې مونږ ویله چې constriction of airways د پاسما کې د airways چې د برونکای د هغې تنګوالی ده، او په bronchiectasis کې چې ده دې کې abnormal غټوالی د airways ده او ورسره elasticity loss ده. Again clearance impairment, the mucus clearance impairment da, or da eventually to the chronic inflammation cause ki, or da risk the infections hum diri, and so it leads to like a progressive lung damage as well. And it's also associated with poor ciliary motility, which we're gonna discuss in further detail. So in terms of causes and etiology to the congenital bronchiectasis is usually cystic fibrosis that are associated the primary ciliary dyskinesia that are associated the primary immunodeficiency show, alpha antitrypsin deficiency show. So basically congenital bronchiectasis yani aga diseases that are associated that genetically, like the mashubtubna pedaishi, cystic fibrosis show, alpha 1 antitrypsin deficiency show. And then you have also got the acquired bronchiectasis. So acquired bronchiectasis, this is like caused by underlying condition or factors that damage the airways, like a chronic respiratory infection. So example, mycobacterium infection, like a TB infections, secondary immunodeficiencies leading to chronic or recurrent infections, allergic bronchopulmonary aspergillosis, which is a or environmental, which occurs as allergic bronchopulmonary aspergillosis usually occurs as a result of immunodeficiencies, and environmental factors like exposure to toxic chemicals, pollutants, like aspirations, toxic inhalation, foreign bodies, ټول acquired bronchiectasis trigger کوي. So bronchiectasis چې am congenitally د پیدایش یعنی بعض disease سره چې associate دي چې پیدایشي لکه cystic fibrosis یا genetically cystic fibrosis show as I mentioned, and then acquired چې that هغه د وروسته develop کیږي هغه د نور so the diseases the wajina nor marazuna the wajina example respiratory infection the wajina example the TB kai and tuberculosis kai ya second immune deficiencies kai ya nor factors like aspiration show ya foreign bodies show pollutants show daga wajid nasa. And primary ciliary dyskinesia primary ciliary dyskinesia, this is when the cilia don't move normally and it basically leaves the mucus stuck in the airways. So bacteria that's trapped in the mucus, they start to multiply and they can cause pneumonias. And if that happens repeatedly, it can lead to chronic inflammation. So primary ciliary dyskinesia, we're going to discuss more about that. It's the function of the mucociliary system. او بل example like cystic fibrosis کې د کې mucus چې کنه هغه خپل extra سي sticky mucus پکې extra sticky نو ځکه هغه ډېر difficulty چې هغه د airways نه سشي باندې اوزي کوي سبا ډېر difficulty so هغه عملته پس airways کې باندې او هغه accumulate کیږي او دا نور هم د pneumonias risk ډېری and then a bul airway obstruction show no airway obstruction diabol cause da so the college example yeah tumor for the airways ki grow kigi you know which results in basically pinching it shut basically it affects the airways and so in any of these situations the blockage prevents the mucociliary escalator from clearing out the mucus and once again it can lead to recurrent pneumonias and chronic inflammations and then also there's certain types of infection like aspergillosis can also worsen the problem because like it can lead to aspergillosis can lead to ABPA so allergic bronchopulmonary aspergillosis and yeah that can cause hypersensitivity response which results in even more inflammation of the airways. Okay, so in terms of pathophysiology, so the mucociliary escalator, that's we're gonna talk about first. So if you take like a closer look here. So what happens is that particularly in the walls of the airways, they got like elastic fibers, which gives them the rubber band-like properties, and they're lined with epithelial cells. So these are the epithelial cells. They're lined by the epithelial cells, and they some of which have like brush-like projections called the cilia on their surface, and others that secrete mucus, like the goblet cells, as you can see here. These are the goblet cells. They secrete the mucus, and this mucus they secrete, they trap foreign particles like bacteria, like dust, and this mucus then gets swept upwards and out of the lungs by the action of cilia. And together, this whole system, this is known as the mucociliary escalator. And eventually, what happens is that the mucus and any of the stuck particles move into the esophagus and then get swallowed and destroyed by the acid in the stomach. So this is the normal function of the airways. So that's the picture, the airways histological structure, the kadalta tasugar bottom kidalta the basement membrane, so elastic fibers, elastin fibers, so basement membrane, and then dagalta the epithelial cell, these areas of baz epithelial cells ki cilias, the dagata cilias mungawayu, and then the goblet cells, these goblet cells, the mucus produce kay. So mucus produce kay. So what happens? Kalache da cilia chi da kalache mucus produce da mucus che da satrap kay. Okay. So the mucus che da asal ke bacteria katasu ga bacteria strap kay yani foreign particles che zamunga airways tarazi foreign particles shikam bacteria kum microbes jaga che zamung sa tarazi airways tarazi no da mucus che da aga sakay trap kay or the cilia the action na da this khwazig is like a how do you say it's like a hair kind of structure da no the action the wajna da mucus che da dagzina koshish ke da cilia چې دا mucus دغه agazina dere zemung dere airways na dere area na da liriki satewisi pesap suibiki izmung esophagus tewisi chi alta pesap you know, so we can swallow it, and then aga acid ches mung stomach da aga destroy shi. Lekin for bronchiectasis ke da mucociliary escalator chida kan da mechanism da akhbala da affect kigi for bronchiectasis ki so da sahi perform nishi kawale cilia impair ki paki sahi perform nishi kawale mucus space up nishi sakigi am dagalta pruti, so these in a kigi na mucus, so it's the mucus not being removed from the region, from the airways, so it stays and accumulates within the airways, which causes problems. So I'm not able to. Okay, and then this is the pathophysiology of the of bronchiectasis. So what happens? So bronchiectasis results from diseases that causes chronic and recurrent inflammation. So the reason that chronic inflammation is so problematic is that over time, immune cells and their cytokines can actually damage the ciliated epithelium epithelial cells and destroy the elastin fibers. So as we talked about it in this previous picture, that it's stopping. As we talked about it in this previous picture, the bronchiectasis da aga daga ciliata or the mucus dishinta like damage cause kai. So what happens, I mentioned that over time, immune cells and their cytokines can actually damage the ciliated epithelial cells, destroy the elastin fibers and the walls of the airways. And over time, the airways becomes dilated, they become clogged with mucus. Fibroblasts move in to try and repair the damage by depositing collagen, and the loss of elastin and the buildup of collagen makes the lungs less elastic and more stiff. So what happens that is stiff, and so has the mucus-filled lungs. It makes it tough for the air to flow smoothly, which leads to pattern of obstructive lung disease. So you can see that this is the ghalta picture, like the mucus build up here, like there's a buildup of mucus in this area. The normal sadazumunga bronchus or the bronchiectasis. So kalache initial insult matlab can be in the form of infection. Initial insult can mean infection, and kalache infection occurs shunu aga inflammation cause kai. So yani pa deki chida. What happens is that kalache cytokines release kigi during infection, chikala inflammation kaki cytokines release kigi, interleukins release kigi, hui zamung daga ciliated epithelium chima previous picture ki discuss ka aga destroy kai elastin fibers the airway chidi dagi the wall aga ham destroy kai au bumurur de waqt sara chida zamung da airways chidi aga dilate kigi au aga ki no da cilia chikala cilia destroy show aga nishi kawala chi zamung da mucus che alta bacteria in foreign bodies trap kai aga nishi kawala che aga mucus da aga zinaliriki no aga mucus chida amma galta zamung pa airways ki accumulate kigi, and as you can see it causes permanent airway dilation, loss of cilia, mucus accumulation, and kalachi mucus accumulation shunu da environment chida kana da nor bacterial colonization ta pesap that did easy kache bacteria ainda easily colonize ki zamunga da airways because of this environment has been created by this process. So that's this. Having okay. Okay, so in terms of the screen yodam stop kigi, so I don't know why this happens, but it just stops all of a sudden. Okay, so let me just remove all of these. In terms of symptoms chida, what happens that you can experience like a daily cough again. So symptoms, the asthma or the bronchiectasis chidi kana the agi symptoms similarly. Difference chida aga pathophysiology ke differences razi, aga diagnosis ke difference razi, or the agi pase ke difference razi, the agi pa ilaj ke treatment ke difference di zyatara. In terms of symptoms, aga similarly like a dekim cough, there's also like production of mucopurulent sputum. Hemoptysis is also present in like 50% of patients. You can see dyspnea. There's also fatigue. Rhinosinusitis symptoms can also occur, such as like nasal discharge, nasal obstruction, or facial pressures, and rhinosinusitis symptoms occurs due to underlying mucociliary impairment. So and there's also, as we mentioned, recurrent respiratory infections, so increased risk of further infections as well. And also in terms of signs, there's also prolonged expiratory time. The expiration is prolonged. There's also wheezes, and patient with advanced diseases may develop cyanosis, clubbing of digits, and cachexia as well. So this is like this picture that you see here. This is an example of finger clubbing. Rhonchi can also occur. So rhonchi, this is like low-pitched noises which sounds like snorings, and these are caused by movement of secretions in the large airways. So per bronchiectasis ki chada agi ke ham tukhe normal da, lekin da tukhe ki chada agi ke agi sputum chada agi mucopurulent da. So aga dir sticky da and they thick da and they like yellowish and greenish da. او هيموبتسيس مطلب يعني کله چې ټوخي سره وینه راځي نو هغه one of the symptoms د خو هغه په example 50% خلکو کې دا symptom یې کله چې ټوخی کې او ټوخي سره وینه درته راځي. اسابندي common دا obviously fatigue یعنی ستړیا د دې obviously وجه دا اسابندي and rhinosinusitis symptomونه هم common دي چې د you know د پوزې obstruct کیږي پوزه بند کیږي لکه زکام غوندې symptoms چې هغه او د هغې وجه همدغه impairment د mucociliary system چې موږ previous slide کې discuss وکړو او دا چې دا future infections چې دی په دې کې هم ډیر یعنی risk د infections هم ډیری په دغه کې په bronchiectasis کې. Oh, in terms of the exhalation period چې دا هغه ډیر اوږده ده. So prolonged expiration مطلب یعنی exhalation period چې دا نفس چې خلک وباسي ساه چې وباسي هغه ډیر prolonged ده. wheezing اکر کیږي, clubbing هم اکر کیږي. دا picture چې ګوري دا example د finger clubbing, cyanosis هم اکر کیږي. rhonchi هغه یو بل sound ده یو خو wheezing ده یو خو rhonchi ده هغه هم اکر کیږي. او rhonchi وجه دا ده کله چې and it's, as I mentioned, it's caused by movement of secretions in the large airways. And then one of the common reasons of why you get finger clubbing is that in bronchiectasis, what happens is that the chronic inflammation and the damage to the airways, they lead to release of like, again, various cytokines and growth factors that promote the growth of blood vessels and connective tissues. So this increased growth of extracellular matrix in the nails can result in finger clubbing as well. So yeah, that's the cause of finger clubbings. And then you have got the erase. I don't want to confuse. Oh, but okay. So in terms of the diagnosis, Chida, You can have laboratory investigation, then you can also have like a imaging investigation too. So for laboratory investigation, arike full blood count chiki, arike full blood count arike like a white blood cell count arike uchati, includes neutrophilia as well. CRP level ham chiki aga CRP chida agam ham uchati, especially kalachi ataxia, acute exacerbations akar kigi, autoimmune screening ham kigi in case if you're suspecting autoimmune condition to be the leading cause of bronchiectasis, and specific IgEs levels are also being checked. So example, specific IgE to Aspergillus fumigatus kamunga charta ABP aspergillosis suspect ku no padere ke specific IgE levels hamchiki. Genetic testing is also done as well to diagnose congenital disorders, because we did discuss that bronchiectasis can be congenital, can have congenital causes, and it can also have acquired causes. So genetic testing is done. Chimunga diagnosed if there's any congenital disorders like cystic fibrosis, primary ciliary dyskinesia show that makes it more prone to get bronchiectasis. And then you've also got the imaging investigations, so like chest X-ray show, it's required to exclude other pathologies, and normally chest X-ray shoda kana aga normal mild bronchiectasis ki chest X-rays normally lekin it's the chest X-ray kaiche nor mariz nor pathologies chi like disease chi aga rule out ki paisa. Bal CT scan हम की and katas the picture where that the CT scan picture da. So it's a gold standard imaging test, and it shows bronchial dilation with or without airway thickening. And then bronchoscopy हम की, and usually patients की कमियों की bronchiectasis localized or the patient की the bronchiectasis वजह aspiration foreign body aspiration या endobronchial lesion or that's one of the causes as well. And then lung function test usually it shows an obstructive pattern. So again, the FEV1 FVC ratio is less than 70% as well, but it can be normal too. And sputum cultures can also be performed to identify specific bacteria that causes the infections in the lung. And if you can see the image ده أصل كده image ده image like da CT scan so da غاړه چې da خي غاړه د lung da او da غاړه چپ غاړه د lung da چې دغه area da trachea da so او بل دغه تور and then the small چې ګوري دغه these ones or these ones or these ones, or you can say these ones, like these are like the bronchioles as well. So they kari the spin around these the airways, the spin the white area around the wall of the air. This is the wall of the airways, and then the black area in between. This is like the air inside the airway. As you can see that the airways have dilated. Katas delta airways like zan dilate kari di the galta, and these the sections ke here. So across there's like dilation the airways clearly CT scans. So yeah, and then man, I can't. So in terms of treatment, the bronchiectasis treatment of it usually involves a combination of medications, airway clearance techniques, lifestyle changes, and medications may include antibiotics to treat infections, bronchodilators, to help open the airways, and corticosteroids as well to reduce inflammation. Airway clearance techniques such as chest physiotherapy can be done, postural drainage can be done, and they can help loosen and remove the mucus from the lungs. And you can also have like lifestyle changes such as quitting smoking, getting regular exercise, and maintaining a healthy weight can also improve lung function and overall health. And in severe cases, surgery may be necessary to remove damaged portion of the lung. So bronchiectasis كده treatment كده medications يعني combination of the medication or the airway clearance techniques. The medication usually كده antibiotics da bronchodilators وركيتش airways زمونغا like azada ki open up ki corticosteroid وركيتش inflammation reduce ki كم ki the inflammation كم ki قبل airway clearance technique شدي أغلقها chest physiotherapy شو يا postural drainage شو أغا help كي جدا mucus شي alta زمون airways كي باندي أغا بيساب إلكي أو كوموكي جي mucus أوزي زمون the lungs نا and lifestyle changes like a cigarette band كوال normally so ورزش كوال أو قبل healthy weight maintain كوال أغام زمون the lung function improve كي and as you can
شيخ ناسا
oh shoot all right so as you can see here this picture, this shows postural, the example, the postural drainage. Postural drainage, it's like this helps remove the mucus. It's basically positions of like sitting and sleeping, that helps in removing the mucus from the areas from the lungs by the help of gravity. So yeah. The certain posture شدي like the kinasto posture the with the kedolo posture the aga kumaki زمونغا the lungs the mucus build up chikigi aga siki aga liriki the with the help of gravity basically. So that the example that the postural drainage, and this is the airway clearance technique. So this is I think all from me. Yeah, I think the picture that I didn't really cover properly. This is asthma damasi cover naka because I could not see it during the presentation and it just came now. So as we mentioned that asthma kichida aga slurry aga from different types slurry from least to most severe type. Step 1 is the intermittent step 2 is the persistent mild asthma kigi, and then step 3 is the moderate persistent asthma and then step 4 is the severe persistent asthma type and the Toluna step 4 is the most dangerous one, and then the rest you guys can read in your own time. And I think that's all from me. So thank you very much for your attention, and let me just stop this.